Good afternoon, everyone. Thank you for joining us for DDU Teaching this week. It's an absolute pleasure to be introducing Alan Ellis, who is the Echo Fellow working with us here at Nepean in Sydney. He was here 2 years ago, I think it was now, and he got his DDU last year, first time. He's absolute Echo guru. It's a real pleasure to have you here, Alan, to run us through a few cases with particular relevance for the upcoming DDU Viva, which has been postponed a little bit, but it will be happening, we all hope. So Alan, over to you. Thank you very much for taking us this week.
Thanks a lot, Sam. So I sat this exam a year ago today, I think it was. And for those of you who aren't familiar with the format, obviously it will have changed somewhat this year with COVID. But essentially, those of you who've done the written then go and do the Viva. The written, you'll have had lots of practice, I imagine, with Sam or with your supervisor. But the Viva station is a little bit intimidating, but not too dissimilar to what we'll go through here today. You essentially get presented with a small vignette and relevant Echo slides. And as I recall, there was at least one non-Echo related ultrasound when I did my exam. I had an abdominal ultrasound scan. It wasn't a fast, but it was sort of just looking at abdominal viscera, and it wasn't your typical one, so it was a bit tricky. But I think rather than, as with most exams, rather than a spot diagnosis, they were really looking for, at least I assume, Sam, they were looking for some deduction about what you're looking at and what conclusions you can or can't make from the images.
That's completely right. I think for the general ultrasound, they're expecting about a sort of a CCPU level, or a relatively basic level of expertise, and that's obviously very different from the Echo, which is the lion's share of the course. There will definitely be a toe image in there. There will definitely be a general ultrasound of some sort. So there'll either be artery, vein, fast scan, lung, renal, gallbladder. Those are the sort of things that we'll be looking at.
And so these images that I'm going to do are what I presented at Lura, which is the Echo conference that happens every year. Unfortunately, it's again got cancelled this year because of COVID, but again, well worth going to just to get a good experience of a few interesting cases. So we might start off. Any volunteers for the first? The first one's quite straightforward, but if it's going to be Vivas, we need a volunteer.
Sure, bring it on.
Okay, and so maybe we'll start with case one. Maybe if you just read it off, and then we'll.
All right, so there's a 91-year-old lady. She's admitted with dysphagia and hemiparesis, which has now resolved. Background AF, hypertension, mild vascular dementia, undergoing a stroke workup. So I'm already thinking about, well, AF, does she have thrombus? Is it going to be transthoracic or toe images, looking for that? Hypertension, she could have changes associated with that. And
not
surely
an unusual reason for an Echo, and probably make up about 10-20% of the Echoes in the Echo lab. Is that coming out okay?
All right, so you're showing me a parasternal long axis view. The LV seems of normal size with exceptional wall thickness, and that's shown on the other picture with measurements. So that's at least that would be moderate for female. The LV function probably somewhere around 50% on that single view. The mitral valve, there's some posterior calcification, and the left atrium looks enlarged, which is not surprising with the pathology. Now, the aortic valve also has some calcification. I'm wondering whether there's restriction in the opening there. That doesn't come through so clearly. The RVOT looks normal size there and seems to function well. There's also a mild pericardial effusion.
Is mild the right term? Small,
Well, it's
moderate, large, physiological?
it's present in diastole, I think, and it's less than a centimeter.
Yeah, so what does that make it?
It would be small.
Yeah, good.
Yeah.
And which of the coronary cusps is restricted, do you think, on that view?
There's a lot of calcification on the right, and it doesn't open clearly. The other could either be the non-coronary cusp or the left-sided cusp.
Okay, sure. Remember, in the exam, you're going to be under time pressure. So if they ask you a direct question, come out direct with the answer. And so in this view, what are the cusps that you see on the aortic valve?
So I see the right up the top.
Yep.
And usually it's the non-coronary cusp down below, but it could be the angle dependent, could also be the left.
Okay. All right.
So I would be at the moment I'm okay. Thank you.
So looking at the short axis, would you try and name the cusps for me? What's this cusp?
Yeah. So you have that's the non-coronary cusp, the right up the top, and then the left to the right side of the image.
Yep.
Okay. So I think there's clearly restricted opening of the cusps. Sorry, the clip doesn't play that well to differentiate where the restriction is that you asked me about. But I would be curious to put some color through there and see what the gradient across the valve is.
I think it's trileaflet, bileaflet?
I think it's clearly trileaflet.
Yeah. Is that coming out all right? Sorry.
So there's an apical four-chamber view as a focus on the LV, sort of dropping a little bit in and out into a five-chamber view. So again, the thickened myocardium outstanding here is the extremely enlarged atria, severely enlarged left atrium, and the right atrium, I imagine, is also large. It's sort of the size of the left ventricle.
Okay. So what are we looking at here?
So someone has done a planimetry of the aortic valve, measuring 0.7 centimeters, which would suggest that it's severe. However, the challenging is already presented in the images, that it's not a regular shape, and whether there's certainty that all of those areas are right at the tip is very difficult to be certain of. So I wouldn't rely on that single measurement. But I'm certainly concerned that she has significant or severe AS.
Yeah. Okay. And so what other things would you think of to do next as part of your workup for severe AS?
So I'll certainly get the gradient across the aortic valve for multiple angles, multiple probes.
Yeah.
So
what does this suggest?
That is a reasonable profile. It's greater than 4 meters per second, which would also fit in the severe category. And also the mean gradient is greater than 50. So that's according to European and American guidelines, would be also consistent with severe. And if you gave me an LVOT VTI, you could also do a calculation of the aortic valve area and correlate it to your planimetry that you've done.
And why do we use the mean gradient rather than the peak, or to determine severity?
So the maximum gradient or is actually the mean or the instantaneous gradient versus the one that you establish with the catheter, where you actually can get the peak to peak gradient. So my understanding is that the mean gradient is just gives you a more general overview regarding the gradient across the valve.
Yeah, correct. So it's to do with the timing in the cardiac cycle, but when you measure the peak to peak or the gradient, it's not directly comparable. And the old way of doing it was doing a pull through with the catheter in the cath lab.
Yeah,
the mean is more comparable with cath lab measurements.
I think you can roughly estimate that it's roughly 0.6 if you have the peak to peak gradient, the mean instantaneous gradient. Sorry, from the mean instantaneous gradient to the peak, it's times 0.7.
Okay. Why have we done more than one here?
So it's interesting. It looks like there's some P waves. You told me that you had a history of AF, but they probably don't consistently correlate with the AF. I think you just want to get as many as you can anyway. So in AF, you would want to take the average of 5, but then you also have shown me only one view, and you want to get it for multiple views, including right-sided views. Just
to emphasize that you need more than one measurement if you've got atrial fibrillation. Depending on what textbook you read, it's between 3 and 5. And I think the ASE recommend 5 measurements. Yeah. And what we're measuring here.
So this is now the LVOT VTI. Not the greatest profile. You could decrease your scale a little bit, increase your sweep speed to 100, but it shows it is 11. So with the continuity equation, you could calculate your aortic valve area from there.
Yep. Anything else you could use to calculate severity of aortic stenosis using the LVOT VTI?
So you could also use it for the dimensionless index.
Yeah. And what
correlating?
Yeah.
Sorry, what was that? I didn't hear you there.
What's severe?
What's severe for the dimensionless index would be less than 0.25, and the aortic valve area less than 1 centimeter square.
Yeah, good. So well done. That was the first case. Pretty straightforward. Yeah. Did you pass that, Sam?
Absolutely, I think that was really good. I like the systematic approach to it, not too many ers and ums, which I'm certainly guilty of doing. And as Alan said, I thought you visualized that very well, Alan. So it's talking about answering the question and understanding there is a time limit. So there'll be a set number of, say we've got 10 questions that we can ask in the 40 minutes. You're absolutely expected to answer at least 5 of them. If you don't answer enough questions, we'll do our very best to shimmy you on through the questions, but you're expected to at least get through 5.
Last year, quite a few of us came out of the exam and said, and I think one of us said, "Oh, what did you get for was it the Curie PE question?" And it all dawned on us that some of us had run out of time and didn't even get to the PE question. So it's in our interest to answer the question quickly and move on. All right. Anyone ready for the next case? Any volunteers for the next one?
I'm happy to.
Yep, sure.
You're getting early. They get harder the longer you wait, right? Yeah.
I'll just read it. A 52-year-old man has got hemochromatosis, collapse in the community, immediate CPR, VF, shocked into AF, ECG, no ST elevation, likely primary arrhythmia, not by cath overnight.
So this is not an uncommon clinical scenario, is it? Someone who comes in and the ECG looks fairly benign, but they're not well, and you do an echo looking for, what do you think you'd be looking for here?
looking for regionals to see if there has been some segmental wall abnormalities. So there has been some, even though the ECG is not got ST elevation, it could be a non-ST elevation.
Yeah.
Looking for a cardiomyopathy that could be associated with an arrhythmia, infiltration associated with hemochromatosis.
Yep. So essentially, this is quite a tricky one, but we'll work through it.
So parasternal long axis view. The left ventricle looks dilated, and the function.
Does it look dilated? Remember, you've got
A little jumpy.
Oh, is it? Sorry.
Yeah.
No, you're right.
You've got your measurements on the side there. Remember, does it look that dilated?
It's not coming through brilliantly, but that's
How is it? Okay.
I thought he's telling
No, I don't think it's dilated.
Okay, we can't see the posterior wall very well on the echo, which means I can't really comment on the function. The septal function looks okay.
Is that the posterior wall or is it a different wall?
The infralateral or the posterior wall, they're used interchangeably.
Yeah.
Okay.
Old school.
Sorry.
Old school, yeah.
No, it's old school. It's lovely. It's fine. I think both will do. I had the same thought. I think more commonly it's called the infralateral wall, and that's probably certainly absolutely what I taught Alan, and that's the way that I was taught at the Mayo. It can be called the posterior wall. That's particularly in English, I think, or a European way of describing it.
Well,
I can get away with that because she's English, like I.
Sorry.
you might think I'm being mean, but in the exam, I had two very much bad cop examiners, and they were making you second guess everything you said. So don't worry. If you're right, stick by your guns. So hopefully this comes out all right, because this is where the money shot is really.
Okay, so at the left it's the parasternal short axis at the level of the mitral valve. The ventricular septum is bowed appropriately from left to right. The right ventricle doesn't look particularly dilated. The function looks reasonable. In the middle is the short axis at the level of the papillary muscle. Again, function looks reasonable.
Okay, anything abnormal on that? And this is where it becomes very subjective. And it's where, if you've got a clinical question that you want to exclude a regional wall, you need to look at every segment on its own and compare them and take your time and do it.
Okay. So the septum, which would be the infraseptal wall, is not thickening as much as the anteroseptal and anterior wall. So at the base.
It's quite hard. At the base, it's quite hard to see the anterior wall. Is it coming across okay?
It's pretty jumpy, but I think we can get the idea.
What, can you see my arrow?
Yes.
So compare this bit here. Oops, sorry. With maybe this bit here.
Yeah, speak up.
Yeah, so the infraseptum is impaired.
Yeah. And then the other views are quite hard to see, but I think the important one is this one. As you can see, these all walls are thickening and coming in. But if you look at the infraseptal and anteroseptal walls,
They're not thickening.
and remember, this is not anterior. The walls of the left ventricle, or the septal walls, are sort of lineated by the right ventricle. So this is infraseptal, anteroseptal, and the anterior walls here. Am I right, Sam?
Yep.
Yeah. So although it's anterior to the probe, it's the anteroseptal wall.
And just again, it's regarding communication. Sorry to jump on your things. I don't want to play bad cop examiner, but we said it was impaired. You said the thickening is impaired. You know, we've got very clear gradings of severity from normal, hypokinetic, akinetic, dyskinetic. So I'd expect candidates to be able to make a suggestion of that. And we can argue a little bit about some of the rows, but what would be definition of normal, hypokinetic, akinetic, or dyskinetic?
The thickening in millimetres,
Yeah.
so 5
No.
millimetres.
Oh, okay, I have it as percentages.
Percentage, 25%.
Yeah, so 50 for normal, hypokinetic less than 50, akinetic 0, obviously, and dyskinetic moving the wrong way of the system.
Yeah, so what do you think of that wall then, the imperceptible wall, Anne-Marie? Akinetic, hypokinetic?
Hypokinetic.
You're going to say akinetic to hypokinetic.
Sorry.
I think this is hypokinetic. I think that looks to me akinetic.
Okay.
But Sam can be invigilator. He's
No,
ignoring.
I agree with you, Alan.
All right. So moving on.
Just kind of
So Sam always used to say to me, if you see it in one view, you got to see it in another view, or something like that.
I've heard that.
And
my chat hasn't got any better. You'll be glad to know.
because the important thing is if you see a regional wall, particularly at the basal left ventricle, it's important that you're not seeing the LVOT. So you need to see it in more than one view.
Okay, so it's the apical forward chamber on the left. So looking in the same area, the infraseptum. There's still an absence of thickening down at the basal infraseptal wall there, which would fit. The mid thickens appropriately, as does the apical segments and the anterolateral wall. So that would be consistent with the basal infraseptal. On the two chamber on the right, it's the anterior wall on the right and the inferior wall on the left, and they look normal.
Yep. Okay. So if you presented this in the exam, or sorry, even if this is a patient overnight, what would you do or say, or how would you report it?
So the overall systolic function, I would say overall, subjectively, it looks low normal to mildly impaired, with segmental wall motion abnormalities in the infraseptal region.
Yeah, so one of my most hated things, and this is me being bad cop again, is people who say low normal. It's either
Thank
low
you.
or it's normal.
Amazing. You said normal.
Oxymoron. You can't have low and normal.
That is that. Yeah, I'm with you, Alan. We talked about this yesterday. Yeah, make it cool. Make it cool.
Going low normal.
No, you got low normal. You can have
50 to
normal or
55.
mildly impaired. You
What's
got
50 to 55?
That's what it depends if you're a man or a woman, right? It's
Yeah.
52% cousin. So we got very clear things. Like if it's over 52 for, then it's normal. If it's under 52, then it's mildly impaired.
Okay, it's mildly impaired.
Perfect. Brilliant.
It's like pulling teeth, sorry.
I'd say, like, the way I'd report this is overall systolic function appears normal. I think that EF is probably more than 52% if it's a man, or 54 if it's a woman. But there is a regional wall motion abnormality that worries me. And
Very
that's
nice.
how I would probably report it. And which regions do you think you'd report as abnormal?
So the basal infraseptal wall. So we'd be thinking RCA territory.
Yeah, or
Also complex.
Or circumflex.
so septum. I mean, I think on that view you've got a hypokinetic anteroseptal wall and an akinetic infraseptal wall. You can't really see the anterior wall very well in most of the images. The problem is with the coronary circulations is that they can overlap. But I would probably say this would be worrying for anterior ischemia, personally. But you can be wrong. Anyone disagree? Sam?
I'd have gone with the right coronary or the circ. I completely agree. I think we know from coronary CTs and talking to smart cardiologists, they tell me that the branches can affect anyone, particularly the LAD can start looking at other areas. But I would have gone for the right coronary or the circ first. But with the septum, you absolutely, it can have the LAD branches affecting it as well. I think anything would be all right in that one. I think the thing we would not be going with right coronary this side is that the right ventricle doesn't look horrifically impaired on the images that we've got.
Yeah. And as a general rule for me, if it's anterior anteroseptal or even infraseptal, and particularly if it's anteroapical, it's always LAD.
Yeah.
If it's a lateral wall, it's CIRC, and obviously if it's inferior and RV, then I think RCA.
I think the apex isn't gone here, I think, which is the...
Again, if this patient is presenting with cardiac arrest out of an LAD blockage, I would expect the left ventricular systolic function to be quite more impaired than this.
Yeah, but thankfully they did an angio and it was LAD.
I take it all back, whatever Alan said.
All right.
Thank you.
Who wants to do case 3?
Yeah, I can do it before I leave.
Can you hear okay? Can you hear Hatim okay? Alan, you know Hatim, don't you?
No. Who's that?
So Hatim is one of the other ECHO fellows that we have here today, intensivist who's joining us from Westmead for a year. Yes, so Hatim's one of our other ECHO fellows.
You'll have to come closer to the screen. You can't see the fear. So do you want to do this one? Hamsim, was it?
Hatim.
Hatim.
So 79-year-old gentleman, prior repair STEMI, complicated by APO and complete heart block, had a permanent pacemaker, admitted late evening with dyspnea and hypertension, more likely septic with acute kidney injury. Progressive increase in vasopressor requirements overnight with anuria and acidosis, rapid deterioration early this morning with unresponsive hemodynamics, quite refractory, MAB 40 and heart rate of 160, and obtunded. Bedside TTE by registrar difficult parts use. Okay. So we have to rule out any life-threatening issues with that, probably pericardial effusion and tamponade, RV dysfunction with acute PE, and in that context as well, any new infarction on top of an old area of ischemia.
Okay. So presumptive diagnosis of sepsis, but clearly worsening organ failure and then rapid deterioration with unresponsive hemodynamics. So that makes you think something else is going on. And I didn't do this. These are from Sam's library, so he knows.
Okay, so, yeah. Okay, so the first one on the left is on the left here. This is an apical 3-chamber view showing quite significant pericardial effusion with RV, with left ventricular systolic function will be quite impaired. I would give it systolic function of like 25% ejection fraction. I can't see anything on the valves. On the right side, I can see a subcostal view of big pericardial effusion with large hematoma occupying and causing tamponade effect on the right ventricle. It's quite circumferential and quite big.
Yeah. So just talk me through this one again. Sorry, subcostal.
So this is a subcostal view of showing very large pericardial effusion, quite circumferential with a big hematoma lying in the pericardium and compressing the right ventricle.
Okay, sure. All right, and I think they managed to get some hemodynamics back for that patient. They did, is that right, Sam? And they did the toe.
Oh my goodness, you're gonna...
So the first one is an apical 4-chamber at 23-degree angle, made of gel, and probably I can't see the full flow across the mitral valve, but looks like there could be some posterior jet of mitral regurg.
Yeah, so you can't see that, can you?
It's coming through, but it's only probably 10 frames a second or something.
Oh, right. I'm sorry.
No, you're good. You're good. Keep going.
I left this in because it's the only toe we've got. But yeah, rather than worry too much about the diagnosis, maybe describe what you can see.
Yep. Okay. So the first one is a made of gel 4-chamber view, and with color Doppler across the mitral valve, with possibly, if we slow it down, possibly there is some posterior directed jet or eccentric jet of mitral regurg, as far as I can see from this sketchy thing. On the top right, I think it's transgastric as far as I can see from here, and I think still it had got a circumferential pericardial effusion.
Yeah, so going back to the image one, how would you describe that MR and how would you grade it?
The problem that I don't have the full picture of the left atrium, so I can do a very contractor out of here. I can do find out the pulmonary veins and find out whether there's anything leaking there, but this is not given in this view. So the only thing that I can see here is just the eccentric jet, and probably given this limitation, I give it mild to moderate.
If you've got an eccentric jet, what would you be looking for?
Looking for flail segments or infective endocarditis or valve pathology.
Specifically for an eccentric jet? If you get a flailed leaflet, you'd probably have quite torrential MR, wouldn't you?
Yeah, exactly, yeah.
Rather than an eccentric jet, but never say never. But if you've got, is that or posteriorly or anteriorly directed?
It's posteriorly directed.
And what does that sometimes suggest?
I'm not sure. So whether there's any rupture of the chordae or that muscle rupture.
Yeah, I mean, it could just be a simple prolapse. It's quite hard to make out.
I can't see really, at least for the anterior mitral valve leaflet, I can't see any prolapse. I can't really see the posterior mitral valve leaflet clearly.
Yeah. Okay. And what about the image below that? So the aorta.
The image below that is descending aorta and showing a big atheroscleromatous plaque in the which region? It will be post through in the right posterior region. Sorry, left posterior region of the descending thoracic aorta.
And how would you, if you were to hazard a guess, how would you grade that atheroma?
This would be at least moderate size. It depends on the thickness. So for this thickness, if it's more than 4 millimeters, it is moderate. It's 1, 4, and 10 millimeters.
It's 1, 4, and 7, isn't it?
Yep.
Millimeters, I think.
Yeah.
Anyway.
Yeah, 2 from 7. Yeah.
It looks severe because that looks like a big
Yeah.
chunk of plaque that's about 1 centimeter wide. So that's not a benign phenomenon. Okay.
No.
So putting all this together, what do you think might have happened?
So probably he had some dissection that extended in the pericardium. So it's aortic dissection that extended into the pericardium and led to probably occlusion of one of the coronary vessels as well. And probably for that there could be some bad muscle or chordae rupture that was related to ischemia as well.
Or tethering.
Yep.
All right. I think that's. And who's next? Have we got Vijeth or I'm not sure who S is.
So this is Sid Agrawal from Darwin. I can give it a go.
Oh yeah, sure.
Yeah. So case for his 46-year-old lady, previously fit and well, admitted with cyclic vomiting and epigastric pain after bee sting, and she presented to ED when she was hypoxic, tachypneic, required non-invasive ventilation for respiration. She had vomiting, she had hemoptysis, very tachycardic, sinus tachycardia, and hypotensive, very labile blood pressure, hypertension to hypertension, rising lactate and AKI. So in multi-organ failure, the CT scan showed ischemic gut, pneumatosis of stomach wall, unable to exclude ischemic gut, though surgeon said too sick for an operation, sepsis needs an intensive care. In ICU, she was resuscitated, secured access, antibiotics, and intubated with sedation, vitamin, and high dose fentanyl. So the
Okay.
potentials for her problems could be, again, GI cause is the most likely, intestinal cause, whether it's a, you know, perforation or ischemia, but I mean, bowel ischemia or some kind of, we don't know whether there's any serious defect in well, whether it is a pancreatitis or just a hematemesis from peptic ulcer disease or duodenal perforation or gastric perforation, any of those possibilities.
Okay. This is a true case from, I think, one of my early night shifts at Nepean. So it's a true story. And the images are pretty bad, but that's all I could get.
Yeah. So on the left is the parasternal longer of the heart. Obviously, very poor windows, but whatever we can see in there, I can't make up the left ventricle, but whatever I could see, probably contracting reasonably well in this view. But of note, most likely she's got a left dilated or enlarged left atrium, which needs to be seen and confirmed in other views, I think. That's as far as I can comment on this image. I can't see any pericardial effusion. And
The short axis on the right, I mean, bearing in mind this person's got a heart rate of 170.
Yep.
What do you think about the short axis here?
whether it is a apical or the mid-chamber short axis view, one of those two, but so jumpy.
What do you think about the systolic function?
What's that, sorry?
What do you think about the systolic function?
Look, it's very poor view, but probably the septal anterior septum and the inferior septum, they are contracting well, but the I think interior wall may not be contracting very well. The inferior wall is contracting and the infralateral wall is contracting, but probably down a bit. I don't know what is the correct terminology for that.
I mean, if you get asked the question in the exam, you know, what is the systolic function as a broad term, try and commit to saying something like there is severe, moderate, or mild systolic impairment. So you're answering the question directly and telling the examiner that you understood the question and what that was being asked.
Yep.
If the images are rubbish, you can always preempt that. You can say within the limitations of the images, I think there is, you know, mild, moderate, severe systolic impairment. Beyond that, I can't really comment.
So probably mild LV systolic impairment, but we need to look at other images and other views to comment it properly.
Yeah. Worthwhile telling the examiner that assessment of systolic function in someone who's profoundly tachycardic can be quite challenging. And that's simply because the frame rate of the echo sometimes doesn't keep up with the heart rate.
Sorry about this.
Sorry? You okay?
Yeah, I'm okay. All good.
We'll go on to the next one then. So maybe try this one.
Okay, so this is apical four-chamber view of the heart in a patient who's very tachycardic. And looking at the left ventricle, obviously that we have not measured this chamber sizes, but just a visual inspection, the left ventricle looks dilated. Left atrium is also dilated compared to the right atrium, and I can't see the right ventricle properly, but seems to be contracting well, whatever image I can see in that. And that's as far as I can comment on this image.
How would you critique this image? What, I mean, anything you could do to improve it?
Could be a little bit foreshortened, I would think. So going a bit more lateral and inferior towards apex might help. Yeah. In terms of it's too bright, reducing the, sorry?
Yeah, so yeah, turn down the gain, yeah.
Turn down the gain, yes. Turn down the gain and probably reduce the low tissue filter might improve the image quality.
What's this here?
Too bright. So I mean, difficult to comment, but and then probably need some kind of contrast image. But there could be a thrombus in there, and it might be just because of the too much gain that artifact is there. But again, needs a little bit more closer inspection.
Yep. So if it was artifact, what would we call that artifact?
It might be a reverberation artifact.
There's a specific name for it.
I don't know.
So it's near field artifact.
Near field artifact.
And tell me again about the right ventricle. What you said, it looked normal. You can see.
I said I can't see it properly, but if I have to make it up, I can see.
Yeah, so that's the key thing, I think, is if you can't see it in the image, you can't comment on it. So although you get the feeling that it's normal, all you can really see there is the annulus, really.
Yes.
So you can't really say that the free wall is moving normally. Yeah.
Yep.
So that's what view is that?
So that is the two-chamber view of the heart, apical two-chamber view, I mean. And again, we can't see the anterior wall very clearly. Again, LV looks a bit dilated. LV looks enlarged. We have not measured the chamber size. The inferior wall, apical inferior wall seems to be contracting well. The basal inferior wall seems to be thickening okay, but I can't see the anterior wall at all, and difficult to comment.
Okay.
Again, sorry.
So this is the next morning. Slightly better views because we've got, rather than me doing it, we've got one of the techs doing it. Does that look normal?
Yeah, that looks, this is a better quality image, obviously. And the parasternal long axis view of the heart showing the diastole, the size of the chamber is probably what, 6, 10, probably normal sized LV. The chamber is not dilated.
Mm-hmm.
The infroseptal wall seems to be a little bit down, but
which wall, sorry?
The infroseptal wall.
Can you see the infroseptal wall in this view?
Anteroseptal wall, sorry. Yeah. Anteroseptal wall is moving, but not thickening very well, I would think. But the infralateral wall seems to be thickening all right. Again, the left atrium looks a bit enlarged.
I would encourage the language in the exam to be a bit more definitive, and rather than saying it looks like it's thickening, stick to the anteroseptal wall appears hypokinetic, akinetic, so that you're being very clear on what your interpretation is to the examiner. Does that make sense?
Yes, it does. Okay. So it's probably hypokinetic.
Okay, good. Just a couple more images. These are just slightly better than the ones that I took. So what's your overall impression?
Look, in general, the heart looks all right. Obviously, patient is still very tachycardic. Heart rate is around 160, 170 beats per minute. But as such, the cardiac function seems to be normal to me.
Yeah, it's a bit tricky because I think it'll be more clear in the next one. There's clearly regional differences which might make it tricky. Oh dear. Can you see that okay, or is it?
Yeah, I can see that okay.
So
extreme right is the apical short axis view of the apex of the heart.
Yeah.
The apex seems to be beating normal. So the apex is normal.
Yeah. But what about the basal part of the myocardium?
Sorry, just getting a bit blurry. Yeah, in terms of basal myocardium. Yeah.
Anyone else like to have a hazard a guess as what they think is going on?
Is that the basal sort of, almost looks like all the basal segments are not moving well? The segments aren't looking much better, but the apex is moving well, if that's thickening normally. So it looks like we've got akinetic basal segments, hypokinetic mid, and normal apical segments.
Yeah.
Yeah.
So it's a bit unusual.
Very.
Okay.
So I think things that come to mind, of course, it could be multi-territorial ischemia, but it also could something be like a reverse Takotsubo with mid segments, basal segments.
Good. So obviously, Sid mentioned the need to do a contrast to exclude a LV thrombus. What do you conclude there, Sid, based on that picture?
I got limited experience in the contrast imaging, but I can't see any defect in the contrast shadowing there. So probably there's no thrombus in there.
Yeah, I'm not sure if you'll get contrast in the exam. Probably not, Sam, isn't it?
Yeah, probably will not get contrast. If you do get contrast, it'll be something very simple, just like what you said, Sid, showing that there's no filling defect or there is a filling defect. It'll just be for LV opacification, which even if you haven't done it, you can still get the idea that there's no filling defect in the lumen of the ventricle there. So if there is contrast, it will be simple.
Okay. All right, and I think I'll move on past this because it's kind of beyond what you need for the exam. But this is just basically showing tissue perfusion, and then this is all going beyond what you'll need for the exam. But just to tell you the clinical vignette, so it's a case of reverse Takatsubos, and it's associated is classically with a pheochromocytoma, and this is just a CT to show the pheo there sat above the left kidney. And that was a patient that was in Nepean that kept us quite busy for a few days. But fortunately, as you can see from this images, once you beta blocked her and resuscitated her, her LV function improved significantly, well, normal, basically, back to normal. Okay.
Is there a mechanism of reverse Takotsubo in pheochromocytoma? Or is it just the stress response?
I imagine it's just a form of stress-induced cardiomyopathy, just from catecholamine excess.
Yep. Okay.
That's about the scientific as I get.
And that's absolutely right, Alan. The answer is we don't know, but we do know that there's a predilection for reverse Takatsubos with pheo. That's all we know.
Thank you.
Still there? No? Jason, maybe Jason. Hello, Jason.
Can you hear me now?
Yep. Can either of you can have a go at this one?
Yeah, perfect. 84-year-old man, background of CCF, previous valve replacement as Venice, AF on apixaban, hypertension, pacemaker, frailty. Issues in community with leg edema and bleeding varicose veins from venous hypertension. Community nursing, blood transfusions. Presented to ED 72 hours after vein foam sclerotherapy. Profoundly shocked, requiring NORAD for circulatory shock. Admitted to ICU with the diagnosis of pneumonia, raising catecholamines, addition of vasopressin, hydrocautious fluid, resuscitation attempted, echo to assess LV function. Okay.
Yeah, so this is another night shift at Nepean when I was a fellow.
Right.
And quite a very, very frail 84-year-old man, but getting worsening shock. That was his chest X-ray that gave him the presumptive diagnosis of pneumonia. It's not impossible.
Yeah.
But this is his echo.
Okay. On the left side, it's parasternal long with the color Doppler in the focusing on the aortic and the mitral valve. Left atrium looks big. Mitral valve looks like it's opening all right. And
sorry, Vijay. If you're in the exam, left atrium looks big is not quite
okay. Looks enlarged.
So the left atrium is severely enlarged, something like that.
Yeah.
Okay, sorry.
Left atrium severely enlarged. Mitral valve mobility opening looks normal. LV size, it's jumpy. It's not moving now.
Sorry, that's me.
The left ventricular function is probably mild to moderately impaired. And the aortic valve probably is a prosthetic valve, which is seated well, but there is probably a chaotic blood flow there, suggesting possible stenosis, but I'll have to look at other views and Doppler to further evaluate that.
So did you say prosthesis?
Yeah,
Where's the prosthesis?
in the aortic, or maybe not.
Well, we don't know that yet, but that's
We don't know.
had a valve replaced. But let's
Okay.
just have a look at the one on the right-hand side here. That's what. Do you know what view that is? It's not exactly clear, but hazard a guess what view that is.
It's probably a parasternal short axis view.
It's actually the right parasternal long, but with the RV inflow view. Okay.
Oh, okay.
So
Oh.
the right atrium here.
Okay. Yeah, the right atrium is severely enlarged with dilated right ventricle as well. And the tricuspid wall is thickened and can't see it opening very well.
Yeah. So take a closer look at the tricuspid valve.
Yeah.
What was,
Sorry?
what was in the history of relevance?
That the pedal edema was worsening and he's had venous sclerotherapy.
Okay. Yeah. Anything else abnormal you can see there?
Look, there's a hyperechogenic structure, which I'm not sure whether it's got independent motion there, but I'd like to zoom and put a color Doppler to further evaluate that and look in other views as well.
Sure. So here you go. This is again the right ventricular inflow view zoomed as requested.
Yeah, look, it looks like there is regurg, which suggests that it's at least moderate.
So it's sorry, Vijay, this is the RV inflow view. Okay, so you're looking at the tricuspid valve.
Yeah, the tricuspid regurg is at least moderate, I would say.
It's quite regurg. It's so if you remember the story, was a gentleman who's 84 who's had a prosthetic valve in the past.
Oh yeah. All right. Okay.
Not as common as the
Tricuspid prosthetic valve. Yeah, right.
So what can you see in these images?
Obviously, there is a chaotic blood flow at the inflow, and can't see any thrombus or overt stenosis.
What about the right-hand side picture? Just what are these bright white things here?
Sorry, on the right side, there is a echogenic structure which is moving independently, which is suggestive of possible vegetation or a thrombus.
Yeah. Okay. And what are these bright white things? What are they?
Could be prosthetic tricuspid valve.
Yeah. And what do we call them?
By a prosthetic, possibly. Doesn't look like a metallic. How
do you tell if it's metallic or tissue?
If it's metallic, you would see an artifact. And if it's a bioprosthetic, you probably wouldn't see a linear artifact going down. Obviously, there's a lot of calcium.
Yes, I think what you're referring to is the acoustic dropout you get with a metal valve.
Correct.
Okay, so if you were to say tissue or metal, you'd say this was?
Probably a tissue.
Okay. So in your exam, you show the examiner knowledge by saying the appearances of the valve appear consistent with a tissue per valve prosthesis.
Yeah.
Demonstrating the lack of acoustic dropout, blah, 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 blah. Okay.
Yeah. Okay.
So these are more images just to illustrate the same valve, but in different sort of off-axis imaging.
Yeah. So on the right side, it's off-axis, probably apical four-chamber view, or could be a subcostal kind of view as well, which again demonstrates echogenic structure, which has got independent motion in the tricuspid, from the tricuspid valve into the right ventricle.
Yep.
And
And what do you make of overall systolic function in that left-hand view?
Yeah, look, the free wall function looks probably mildly impaired.
What do you mean the free wall function?
The free wall of the right ventricle on the left-hand side.
Can you see that well?
Not able to see very well,
Yeah.
but
Okay.
it's kind of coming in and out.
You can see more of the free wall on the right-hand side one, but it certainly doesn't look normal. What do you reckon about the left ventricle though? Because the question was LV systolic function.
Yeah, look, the LV systolic functions is probably mildly impaired with the mitral valve opening well.
Okay, you sure about mildly?
Probably towards mild to moderate, I would say. But it's not severely impaired.
Oh, yes.
But it's not severely impaired.
If the examiner says, "Are you sure?"
Okay.
Usually means that he's asking you to change your mind, and probably not to sit on the fence even more. So it's either mild, moderate, or severe. And
Severe.
it is subjective, so you could, you know,
Yeah.
you can say it's mild
Yeah.
or moderate, but you have to somehow support that. I
Yeah.
certainly don't think it's normal. Yeah, agreed.
Yeah, I mean, it's moderately impaired, I would say. My only reasoning is because the mitral valve is opening and closing very well. If it was severely impaired, probably the mitral valve wouldn't have opened very well.
Okay, yep. All right. Let's have a look at that then. If you look at that four-chamber view,
Yeah.
you get a better idea of what you think overall systolic function's like.
Yeah, it's severely impaired with the left ventricular function severely impaired with dilated biatria, right more than the left, and the biatria is severely enlarged, which signs showing of severe right atrial pressure increase, suggested by the bowing of the interatrial septum towards the left.
Good.
And coming to the right ventricular function, it's probably moderately impaired with the tricuspid bioprosthetic valve seated well. And on the right side is the continuous wave through the tricuspid bioprosthetic valve, which shows pressures up to the peak pressures up to 1.5 meter per second.
Okay.
Which is high. How
do you know this is continuous wave, going back to some physics?
Firstly, it's the sample gate is the single line on the in the view. It's not the double one. Yeah. And on the picture itself, the velocities are higher, which suggests it could be a continuous wave.
Yeah, I think that might be centimeters per second rather than meters per second.
On the right side, it says meters per second.
More about the profile, really. What tells you that it's continuous wave? Goes back to physics. I'm not sure if you'll get physics in the exam, but
yeah, I'm not sure what wording you need to use for that.
Okay, well, the profile is filled in, isn't it?
Yeah.
Continuous wave rather than it's got a spectra. Okay, so it's a filled in gradient, so you know that it's continuous wave. If it was a pulse wave, you'd have this nice black envelope in the middle. Yep.
Yeah, correct.
Good. Right.
Again, on the left side, it's apical four-chamber view with the color Doppler towards in the mitral area, suggesting mitral regurg, which is at least moderate because it's hitting almost the posterior wall.
What are the cautionary tales with color Doppler and mitral valve assessment in these sorts of patients?
Obviously, it can be overestimated if the gain is high.
Yeah, or underestimated if the
scale, the gain is low. And obviously depends on what section you're cutting at, and it could be an eccentric jet, underestimating the severity of the mitral regurg.
Okay. Yeah, it's more to do with the fact that you might have a left atrial hypertension, and so the gradient between the two might
Oh, yeah.
not be as high as you think it is.
Mm.
And so your color Doppler is not going to detect as much a velocity change. Okay. So what you really need is regurgitant volume to determine the severity of the MR. But that's
Yeah.
why you need caution with color Doppler. Okay.
Yeah.
All right. Good. Let's move on.
And on the right side,
Yep. Sorry, Vijay.
so I was just commenting on the right side on the tricuspid. And I sort of think the pressure changes are much more enhanced on the right ventricular, on the right side of the heart. But if the pressures of the right atriums are high, then the severity is like greatly underestimated.
Okay. All right. That's the valve.
And this is the zoomed in view of the tricuspid biprosthetic valve.
So just in the interest of time, what are we looking at here?
You're looking at the VTI through the tricuspid valve, and it's high. I don't know the numbers, but it looks very high.
Yeah, I'm not sure you'll get
89 centimeters.
measured quite a few different. If you were to critique this, what do you think about the measurement of the?
Obviously, they've eliminated the fuzz, which is good. But the rapid equalization of the pressures is shown here by the downsloping of the profile, the Doppler profile.
Yeah, not sure.
Would you say so?
Because it's not a regurgitant. This is right. This is RV inflow.
Inflow, yeah.
Not like a regurgitant jet where a triangular profile looks like it's severe. This is into the valve rather than regurgitation out.
Yeah.
So I'm not sure you can make that conclusion. Anything else about critiquing this that you might want to, where my arrow is?
Yeah, the baseline's high. I forgot the word used for that. I think it's. Sorry, what was that? Sorry, what was that?
So I've forgotten what it's called as well, but this blackness under the thing, you should turn that down so that the whole of the spectra reaches the baseline. Yep.
Yeah.
Is it called wall filter or something?
Wall filter, yeah, that's it. Thank you. So what do you make of the gradient? I mean, it's a prosthetic valve, so generally you need to look it up, but it's not often that you have a prosthetic valve in the tricuspid location, and there probably isn't any normal values for the tricuspid valve. Am I right, Sam?
That's correct. In the guidelines, the ASC guidelines, they say there's not enough data out there at the moment to give you proper data on the tricuspid valve. But I think they say if it's over 4.5 or 5.
In a native valve, it's 5.
Yeah.
Right.
Valve, but obviously this is prosthetic. But certainly, what do you think about that gradient? Increased, decreased, normal?
Increased.
Yeah. So if you'd hazard a guess, do you think that's a hemodynamically significant valve problem?
Absolutely. Yeah. It's yeah. It would be hemodynamically significant gradient.
All right. And I think we're just looking there to measure cardiac output.
Cardiac output.
Putting it together, how would you present that as a nice summary for the examiner?
So I think the cause of shock would be distributive, with the cause being, it's very important to rule out infective endocarditis on a background of looking at a hyperechoic structure with independent motion. And obviously, it's severely affected with right heart failure. So you would treat the patient with all the right heart protective measures, like diuresis, reducing the PEEP, acidosis, oxygen, CO2, and all of that.
So what I'd say is, like, if you believe this this Doppler assessment, which I'm not sure I do, to the cardiac output looks normal there, or at least not appropriate, okay. So I think there's probably a combination of septic and cardiogenic shock here. And I'd probably say that tricuspid valve is clearly not normal. There's either a vegetation or a mass associated with it, and this patient had foam sclerotherapy. So, but interestingly enough, this is all post-mortem. This patient grew
Wow.
serious in blood. So it's
Mm.
likely an infective endocarditis.
Right.
Is that helpful?
Yeah.
We want to do the next one. Have we got time, Sam?
I'm afraid so. I think we're out of time, Alan. It's 3:10, so I think we probably better pull up stumps there. But
Okay.
maybe just say thank you very, very much, Alan. That was absolutely fantastic to go through those 5 or 6 cases there, and really useful. I hope they were useful for everyone who's sitting the DDU exam this year, because it's certainly along those lines. So thank you very, very much, Alan.
Thank you, everyone.
All right. Thank you.
Thanks, Alan.
Thank you.
Thank you.